So we're good to go then. Okay. So the theme of this webinar is CBT. There's a lot of content in it, so that's why I'm using slides rather than just talking to you, because otherwise you probably have total information overload, which you may do anyway, but at least you've got the slides to look at to give you the key points. And the purpose of the webinar is to give an overview of CBT, and it's purposely focused for those people who are working in some way with other people, whether in the corporate sector role, in a sales, perhaps a coaching role, someone who's in the helping professions, the medical profession, well-being coaching. So there's a wide variety of people that we teach. My particular specialism I'll explain to you shortly, but the whole purpose of everything that I do and that Transformations Institute does, which is the institute that I co-founded and I'm the principal of, is based on positive psychology, applying positive psychology. So whichever modality we're using, the focus is on positive psychology. And I'm going to give you a little bit of background this evening so that you can understand that there is a number of different strands and traditions in psychology. And there's a very specific one that I'm going to focus on and which CBT incorporates very well into. So this is probably the most crowded slide you'll see this evening, and it's not so that you memorize everything that's there. You can see there, what you can see is a variety of some of the logos of the organizations that we are accredited with or registered with or approve. In some cases, actually rubber stamp if you like. You'll see CNHC down there, which is the Complementary Natural Healthcare Council in the UK. You'll see a variety of others. The only ones that aren't British ones there, NACBT up in the top right hand corner, that's the National Association of Cognitive Behavioural Therapists. That's actually based in the States, in America. And down there you'll see Society of NLP, because Phil and myself are two of the very few Society of NLP trainers that are based in the GCC region. There are not many others. There's a lot of NLP trainers, but not Society of NLP, which is the society that was originally founded by the creator and co-founder of NLP, Dr. Richard Bandler. So we work with Richard. You'll see the one over in the other corner down the bottom there, that's the Canadian Counsellors and Psychotherapists Association. Up here we have National Council of Psychotherapists and the International Council, which is its sister organisation. And the course that we'll be teaching in August that's coming up, that we've run a few of online now, and it's been going very well, are accredited both by APHP, which is the Association for Professional Hypnosis and Psychotherapy, and also accredited by Essex Institute down here. And there are other organisations, but I thought the slide was already crowded enough by now. So this is just to let you know that everything we do that is a professional training, not a short webinar or a short introductory like this, but anything that we teach that actually has an assessment process, that is an accredited training. Some of them have exams, some don't, but they're all accredited by professional associations and bodies, as you can see. This is us. You don't have to believe what I say about how good we are. We have plenty of students and graduates who'll say that as well. But we like to let you know that we've been assessed by our peers. That's to say, in this case, the Association for Professional Hypnosis and Psychotherapy. There are a number of organisations around the world that are affiliated to this body that's based in the UK, but it is international. And in this case, we're receiving an award, and we've won 2 of them in the last few years as being the School of the Year. And what that means is that the number and the quality, the grades and so on that our graduates have achieved have put us up there at the top, and on 2 occasions, actually the top in the world. So that's us in London showing off, receiving our certificate, our glass award there, our trophy. I want to just clarify with you a few roles, and this is where it's a bit tricky if nobody's able to talk to me, because I do like to ask you what you know about these. So anyone that is able to unmute themselves or to speak or even to write into a chat box, if we just go through these roles in the field of mental health and well-being, what do these people do, and what qualifications do they need to do it? So if we first of all take a psychiatrist, what does a psychiatrist do, and what training and qualifications do they need? Anyone, at least certainly 2 of you who are psychology students, hopefully might be able to answer that one. What does a psychiatrist do, and what do they need to be qualified to do it? I'm waiting. Don't make me do all the talking for the whole of the session. Come on, I know a couple of you psychology students are in there who should be able to tell us at least what a psychiatrist does. It doesn't have to be them, it could be anybody else that wants to volunteer. What does a psychiatrist do? What training qualifications do they need to be a psychiatrist? Nobody going to give me any idea that they have at all? I think that'll be a first ever. Come on, someone chip in. Okay, well, be like that then. I shall continue, but anytime you decide you want to find your voice again, please speak up. Because as I said, I'm not just saying this, this is the first time ever I've run a webinar where nobody has answered a question that I've asked. You don't have to get the answer right. You don't have to know for sure. Ah, Ebtihal, you're going to say something? You're waving at me. I can't hear you because you're muted.
Hi.
There, go. Hooray, go ahead.
Yeah, this is what I wanted to say. No one can answer because we are muted. You have to tell Illumination not to mute us so we can exchange.
Right,
You know.
I haven't got you muted. I've actually unmuted. Can you hear this, Pia?
Yes, Dr. Leila.
Someone's saying that you've got everybody muted. Is that right?
Yeah.
I'm not allowing them to unmute themselves during the discussion. So if we need, I will unmute one by
No, can
one.
you unmute everybody now? Because as we go through, I like to be
I
able,
am requesting them to unmute themselves, but some are decided not to.
Yeah, that's obviously that's their choice. We can't force them, but I would like to be able to hear from anyone who is able to.
Yeah, I requested it already, so it's their discretion.
Great. All right, so in answer to your question, Ebtihal, Pia has sent out a message to everyone saying please unmute themselves, but some people haven't. But as I've got you now, and you're not muted, what do you think a psychiatrist does and what training and qualifications do you think they need?
I don't know about training. I'm not a psychologist, but I can't in a professional way, but this is my idea, is that when a client comes with a problem, it's mostly going through details to analyze, what is the situation and what, and factors, and come with a conclusion. Okay. I think psychologists, no, that's a therapist, sorry. It's more
but what you've just said applies to anybody who's a therapist, sure. In terms of an actual psychiatrist, Tara, I see you're unmuted. What would you say is the difference between a psychiatrist and anyone else on that list?
Psychiatry basically who has a master's or PhD basically, and there's they are medical doctors, a kind of like a mental health doctors who diagnose a patient using psychotherapy's method.
Okay, if I chip in there, some bits you got right, absolutely right, and other bits no. Although it would be nice if it were true, unfortunately it's not. So the bit that you got right is a psychiatrist has to be a medical doctor. Okay, so they're an MD. They just do a regular MD training like any other doctor, which is usually a 3, sometimes a 4-year program, depends on the country and what degree they do. But essentially a minimum of 3 years as a doctor to qualify as an MD. Then they don't actually need a PhD, they don't need a master's, but what they do need to do is to then do postgraduate specialism. And usually the way that medicine works, they do that in the hospital, in the medical context. So they serve as a junior doctor, and if they want to be a psychiatrist, then obviously they work in the mental health field, as you say quite rightly. What isn't right, and which some people may be shocked by, which is why I ask people, I always like to know this, because a lot of people, even though people are much more literate and know more about mental health nowadays, there is actually a huge amount of ignorance about the field, about what's required. So actually a psychiatrist does not have to do it as a therapist whatsoever. They don't have to be a psychotherapist, and in fact the majority of them aren't. Some of them may be fortunate enough to go to med schools or to study in places where they do provide training, and it's very often in things like CBT, in structured. But as you'll see when we come to look at how CBT got to be invented in the first place, it was actually by people who came from the background of both medical psychiatry and also psychology. And then they studied as psychoanalysts so they could be psychotherapists, and found that actually it didn't really help them very much. So we'll talk about that more later. The main thing, what is it that a psychiatrist can do that none of those other people can do? Bearing in mind now we've discussed it's a doctor, a medical doctor.
Medication.
Yeah. Nobody else on that list can prescribe medication. Now, I'm not going to spend a long time on this. It's actually the subject of a whole module that we do on our training when we train therapists, hypnotherapists and psychotherapists and so on. But actually, there's a big problem at the moment, and that is the fact that psychiatry is actually doing more harm than good. And there are books about this, including books by psychiatrists, by the way, not just people who are critical on the sidelines, because medication is intended for physical illnesses and diseases. I know it doesn't always cure everything, and there's lots of things that doctors can't help with that actually to do with culture, sociology, emotional well-being, mental health, all the rest of it that affect people's bodies, the mind-body spectrum. But the problem is that psychiatrists are trained as if mental health was actually a physical disease, and the fact is that it's not. There is absolutely no sound evidence whatsoever that the 600 and 400 official, and then a whole other variations of so-called conditions, diseases, disorders that are in something called the DSM, the Diagnostic Statistical Manual, which is around the world. There are different versions, but basically all psychiatrists sign up to this. And what they are, and people are often shocked to learn this, there is no research evidence that any of this stuff is based on. It's based on people's opinions. And you know how those disorders that you've probably heard of, you know, ADD, ADHD, all sorts of labels, borderline personality disorder, various things that people get told that they have. Do you know how they get into that manual, how they get listed? And then the psychiatrists decide all the different medications that they should give to people who, once they've got a diagnosis for the disorder. Do you know how they get into that book? If it's not by research, which is what you would hope, right? Speak up, Ebtihal.
Well, most of the illnesses, mental illnesses, is just by doctors, but there is no real research or like physical research or proof it exists. This is why it changes every
it's socially constructed, it's culturally defined. If you're in India and you take off your clothes and you have a begging bowl, people will often call you a sadhu, a holy person, a spiritual person. If you do the same thing in downtown Dubai or in London or whatever, you're probably going to get carted off by the police to get sectioned in a unit for psychiatric disorders, etc. So what we describe as being behavioral issues, how people behave, how they conduct themselves, is very much defined by the society and the culture. So trying to give it a disease, you know, if you go to your doctor and they say, I think you might have tuberculosis, and you say, well, how do you know? And you've got the symptoms. Yeah, but do you know for sure? They would be able to take a blood sample, right? They'd be able to check, they'd be able to have the labs look and say, yep, you've actually got TB. You've got what we call an etiology. There is actually a bacterium or a virus or whatever that they can say, yeah, you've got something. But you can't do that for mental health conditions. And when they talk about brain chemistry, the problem is that brain chemistry, they said, oh, is it genetic? Well, no, actually brain chemistry changes moment by moment depending on what you're doing. If you're happy, it changes in one way. If you're sad and miserable and upset, if you've been fed up with being locked inside for months and months at a time, your brain chemistry is going to change, and it does it literally moment by moment. If you exercise, you change your brain chemistry. If you look at your child or a puppy dog, your brain chemistry changes, right? So the problem is that psychiatry is really not a science-based profession. It's one of opinion. So to answer my own question, which I asked you, how those conditions get into that book, into that list, which is updated every few years, they vote them in. So a committee gets together, and if they think it sounds convincing, literally they vote. And if anyone's interested in following up on this or thinks I'm just making up these stories, just follow up with me and I'll send you references to very learned professors at Harvard, clinicians, etc., etc. And there is actually a set textbook that we set our students that's called Cracked. And the subheading of that is why psychiatry is doing more harm than good. Because the problem is the medications that they are giving people right now, it's very popular around the world, popular here in Dubai, the medications actually can cause the problem to be worse than it is in the first place. And again, I have many clients, and my students and graduates have many clients, and they'll say, do you know what's in that pill you're taking? And they'll say, no, I have to take this one in the morning and this one in the evening, etc. Yeah, but have you looked at the pack insert that's in that pack? And guess what you'll find on the list of potential effects of taking that medication? So you've been given it because you're depressed or because you're anxious, right? Or whatever reason it might be. You've been given the medication, and then if you look on the list, guess what you find on the list of the things that it can actually produce, make worse, even start off in the first place, and you will find things like depression, anxiety, and even, get this one, I'm taking this pill for depression, right? And guess one of the things it can do? Increase suicidal ideation. In other words, make me think of suicide when I wasn't already. So as I said, I won't spend a long time on all the other ones, but I just like to get that across, that the problem is that anyone who's a psychiatrist who isn't actually open-minded and does their best to avoid being told what to do by the pharmaceutical industry, that's what it's driven by. It's driven by profit and by motive to sell drugs. And the problem is that they're getting to a point where they're saying that almost half people, and it's going to be more soon than half, are going to have a mental health problem at some point in their life. And what do they mean? You're going to get upset. You're going to get confused. Maybe you're going to be grieving because somebody died, or you lost your job, or the world's in a terrible state. Does that mean you are psychologically sick the same way that you would be if you had a disease? No, it means that you're unhappy, you're sad, you're confused. And so this is where the therapy comes in, because a good therapist can actually help someone to sort out their state, their emotions, their thoughts, and start to get back in control and on top of themselves. And that's really what this is all about, and the work we do is all about. A mental health or psychiatric nurse, anyone know what they need as qualifications? If someone's going to work in the mental health field as a nurse, or mental health nurse, psychiatric nurse? No? Yep.
No.
Tara? You're speaking, but you're muted, so I can't hear what you're saying.
Yeah,
No,
I mean, like, I'm not sure. Maybe degree, because it's just
It
a
depends
nurse.
on the country is the answer to that, because in some countries you need a degree to be a nurse. In the UK, they changed things some years ago. So I was actually teaching some nursing students many years ago. And a few people say that they're not so good, the nursing, as they were, because although they are more academically trained, they don't focus so much on the caring role that they used to have. But usually in most parts of the world, nursing qualifications take 3 years approximately to get. It used to be 2 for an enrolled nurse and 3 for a registered nurse, but it's around 3 years. They can give the drugs to the patients that the doctors prescribe, but they can't prescribe, right? They can't actually prescribe. So often people think psychologists can prescribe. As you know, Tara, I'm sure psychologists can't prescribe. Their job is to actually work with people, understanding them from a psychological point of view, but they're not medical doctors unless they've trained as a doctor as well. So a psychologist, in some parts of the world, you can call yourself as a psychologist, even if you've got no degree at all. And someone said, well, where did you study psychology? You could say the University of Life or the University of Hard Knocks. But in some countries, it is a legally controlled word. In the UK, it's not. But as soon as you add any of these other words to it, then it has to be legally controlled. So you could be a clinical psychologist, educational, health, organizational, etc. And what do you need for that? And I'm sure that, that our psychology students will know that. In order to be a clinical, educational, health or organizational psychologist, as well as your degree, which is usually going to be 3 years minimum, what do you have to do as well?
Training.
Yeah, so you have to do at least usually a 2-year postgrad, which would be a diploma or a master's, and specialize in one of those areas. And then you are legally regulated. In most countries, you have to register the same as any other medical professional or health professional. So we talked about psychotherapy. What's the difference between a psychotherapist, a hypnotherapist, a counselor? What's the difference between any of those things there?
I think
Go ahead.
You can go first.
Okay. A psychotherapist analyzes, you know, from a student of hypnotherapy, a psychotherapist analyzes whatever situation the client's in and work with them while they're conscious analytically. But a hypnotherapist doesn't work with a client when he's fully aware. He is fully aware, but not fully aware. Like, we have to put them to, in a hypnosis state and go emotionally or subconsciously rather than consciously.
Okay, so that's the key difference between a psychotherapist and a hypnotherapist would be that actually, in my view, a properly trained hypnotherapist does need to do more than just put the person into the hypnosis state. They need to have the pre-talk, as we call it in hypnotherapy, which is to do the analytic work, if you like, with them. If someone's just learned what we would call hypnotricks, basically put someone into a trance state, into a relaxation response state and give them suggestions, that can be very useful, but it's only going to get you between 30 and 60% results in terms of the whole spectrum. If you're doing analytic work, if you're doing regression to cause, and if you're using more other kinds of modalities in with you, what you do, you're likely to get between 60 and 95% success rate. So hypnotherapy, when combined with psychotherapy, is in our experience and from research, a very powerful tool. But you use the words that's important there, which is the main difference is that a psychotherapist won't necessarily work at the level of the subconscious, or if they do, it's indirect. It comes about through the person gradually feeling safe and relaxing and trusting. A hypnotherapist specifically learns how to put someone into that state so that they can access the subconscious levels of the mind rather than working with the purely conscious level, which only constitutes about 1 to 5% of our minds at any one time. So that's where a hypnotherapist has potentially a lot more scope for being able to make changes come about effectively. But I would also say that a hypnotherapist who hasn't learned any psychotherapy is not probably going to be very effective, except with people who are highly suggestible and ready to change and nothing too challenging in the difficulties they're bringing. So a counsellor, I just wanted to say this is a confusing word, because counsellor, the word traditionally means give advice, right? To give good counsel. So even in the holy books, they talk about wise people giving good counsel, elders, respected people, spiritual teachers, and so on. But actually, in the modern sense, counsellor is used both in that way and in a different way, because advisory, like a school counsellor, might well be giving advice. An academic counsellor might give advice about the course you're on, or should you be on it. A careers counsellor might well be giving you information about what sorts of jobs might suit you. But in the therapeutic sense, what we call person or client-centered counselling, that's not the same thing. You don't give people advice, you guide and support them to actually finding their own solutions. So that can be confusing for people when they hear that word counsellor. And then, of course, we've got pastoral educators, people who are tutors who support students with their personal issues as well as academic issues. And we've got social community workers. And now in the last sort of, 50 years really, since coaching started as it is, instead of sports coaching, coaching just for people who are doing sport, but now we have executive coaching, life coaching, health coaching. One of our participants tonight mentioned about executive coaching. So now we have a whole field of people who are not working therapeutically. And one of the easiest way to distinguish between someone having coaching and having therapy is that when people come for therapy, they think there's something wrong with them and they need to be fixed to get themselves better. When they come for coaching, they don't think there's anything wrong with them, but they want to get better at whatever it is they do. So coaching is about enhancing performance, increasing potential, etc. It's not about therapy unless you train for both. So all of these people can incorporate CBT into their work. So I hope you don't mind me spending a little bit of time on that, because people are often confused and they go from one thing. Some people who are trained as coaches and they get themselves in difficulty because they start going into emotional areas that they really don't understand. And similarly, some people try and do therapy on people where really they don't need therapy. They need coaching to help themselves get a new job or make a change in their lives of some sort. Usually when we train people, we like them to train so they can cover the whole spectrum, but then we take 2 years to do that, and it takes longer. So here's the main psychological approaches to help you make a bit of sense of what I'm going to talk about now. Here's the main approaches. There's something wrong. And this is what we call deficit psychology. And this is where psychology started about 140 years ago. This is when really in the end of the 19th century was when psychology really began as a serious profession and study. And actually it was conducted by neurologists, by doctors, medical doctors who were working with people who were in asylums, had been called insane or were in a bad way. And so they studied people who had things that were wrong with them. They were in a real mess often, they were in a bad way. And Freud, probably most of you have heard of Sigmund Freud. He's often thought of as being the founder, the inventor. He's not actually, he wasn't the first, but he's the most famous in many ways. He had the best PR. And what Freud believed about people was that they were basically really in a mess, a bad way. We were cannibalistic, savage, incestuous, and so on. And we needed society to keep us in shape. But sometimes we got so repressed, particularly in our sexual instincts, that we became neurotic. And so the whole of psychoanalysis since, you know, the end of the 19th century is all about trying to help people get rid of their neuroses. The trouble is there's very little research to show that it actually works. Then we've got something going on, which is behavioral psychology. Well, something's happening, people behave in certain ways, and then we go into humanistic psychology. I'm going to come back to behavioral after. And humanistic psychology, a guy called Abraham Maslow, the psychology students may well have heard of Maslow, and some of you may have seen this pyramid of needs, you know, up at the top you've got self-actualization, down at the bottom you've got physical needs, survival needs to be met. And he was the first psychologist to say, why, if we want to understand people, do we only study people who are sick? Why do we just study people who are unwell? Why don't we study people who are well? So here you could say the beginnings of positive psychology really started with Maslow, although there were some in the early days that also had a different perspective. And now we're moving into the last 30 years, particularly the last 20 years of what we call positive psychology. And this is the thought that there's something better. So we've got something right here, but now how about we could do something even better? Instead of studying people who are sick at this end of the spectrum, why don't we study the people who do really well, who are really, really successful at what they do, and learn from them? And you could see that those of you who are NLPers can see that neuro-linguistic programming has got elements of that in it, and so is humanistic psychology. But here is what we're going to concentrate on, and I'm going to tell you about how they can be blended together. So I'm going to also mention this because I know that a number of you, whenever we do anything with Illuminations, there's usually at least some people who are studying hypnotherapy or practicing hypnotherapy. So it's important to know that in recent years, as you can see, I'm not going to read out the whole of the slide, it's just there to give you some information while I'm talking to you. But there's, in the last few years, we found there's been quite a bit of good research done on this as well, that if you combine CBT, Cognitive Behavioural Therapy, which is what I'm going to focus on this evening, with hypnotherapy, you can actually get even better results than you can by using one alone. And that's because one focuses on the conscious mind, the CBT, whereas the hypnotherapy focuses, as Ebdihel was saying, on the unconscious or subconscious mind. So actually, a combination of those two seems to be more effective than just one alone. So this Milton Erickson here, if you're an NLPer, you'll recognize the Milton model, language patterns that are used in hypnotherapy. That all hypnotherapy tends to teach this, and NLP teaches this as well. And this is the art of talking to people in a way that actually changes their perspective. You don't necessarily have them close their eyes or do any formal induction into hypnosis. You just talk to them in ways that actually accesses their subconscious mind and influences them by the way that you talk to them and the stories you tell them, etc. So Erickson was a psychiatrist, but he stopped prescribing medication and stopped doing formal conventional psychiatry and started to use hypnotic language, and that's why he was studied by the Richard and John, who invented NLP, got NLP together and off the ground. They studied his working methods. So that leads us neatly into NLP, and I know from what you've said, at least one or two of you are trained in NLP. And NLP, the neuro-linguistic programming, and the coaching programs that use more and more now NLP, because it's extremely effective. It takes coaching to a whole other level than the sort of traditional coaching models did. And it's all about the nervous system and using the 5 senses, the language that we use, not just the verbal language, but the body language as well. And then programming, meaning the ability to organize the way we communicate using our neurobiological systems to get specific goals and results. So NLP is all about changing yourself in the way that you want to and influencing others. And the 3 therapists you can see at the bottom there, Virginia Satir, who was the mother of modern family therapy, who's someone else we're great fans of, and we sometimes do a bit of training in Satir work. Fritz Perls, who invented Gestalt therapy, and some elements of Gestalt therapy are usually taught in hypnotherapy and psychotherapy, like inner child work, the empty chair, the sorts of things that people can take the technique without learning the whole system, and Erickson, who I mentioned before. So, positive psychology, there was a declaration made back in 1998, so we're talking about fairly recently, by Martin Seligman and Mihail Csikszentmihalyi, and you can actually go on YouTube and there's a video telling you how to pronounce his name properly. So if you want to do it as better than me, then go on YouTube and check out how to say his name. But he's an American psychologist, and what they said is, you know, basically like this humanistic tradition, people are basically good, they're okay, but there's something even better. And since they started working together, a whole bunch of people are all working together in this field of positive psychology, and we're finding some really interesting things that some of you may already be doing in your practices, like the happiness advantage, the idea of doing certain activities on a daily basis, which change your brain chemistry, changes your mindset. So CBT works very well within this field. I'm mentioning, because again, there's usually someone, and I know that Ed mentioned this, who have done energy work, who've worked with access bars, theta, Reiki, etc. And we put this generally under the field of what we call energy psychology. And there are many, many people here. We've worked with all of them at various times, either through their books or in person and so on. And we have very well known Deepak Chopra, Dr. Joe Dispenza, very big deal nowadays, and his meditations and his retreats and so on becoming very well known. Bruce Lipton, epigenetics, the biology of belief. So these are the people who say we can actually change the body side of things by changing the mind. So instead of just having a healthy body and therefore a healthy mind, we can actually do things at a meditation and energetic and thought level that will affect the mind. Again, CBT works very well collaboratively with these, because you do have to look at your thoughts and your feelings and your mindset if you're going to practice any of these things as well. So let's talk specifically about CBT. CBT's got ancient roots based in Greco-Roman and Eastern philosophy, and the big thing about CBT is that we use what's called inductive reasoning. That's the Socratic approach. So the philosophy Socrates, I expect most of you have heard of his name, even if you don't know much about him. One of the things that Socrates did was he just used to question people and ask questions to the point where they became aware of the contradictions in their own thinking, what we call in psychology cognitive dissonance, where you have a conflict between one thought you have and another one. You think something and you think something else, and they don't actually match together. So Socrates was really good at getting people to actually question themselves, and this could actually be very challenging to authorities, because most authorities over the whole of time, not just back in Socrates' day, don't like to be challenged. They don't like it when people question what authority is doing. So Socrates became very unpopular with the with the politicians of his day, and they told him, you're going to be exiled if you don't stop asking people questions and getting them to question themselves. And he said, no, I won't leave. I'm not going to leave. I love Athens. It's my home. So basically, they put him to death. They made him drink poison. They made him drink hemlock. Because they didn't like people asking questions. And I have to say, having lived through this whole situation in the last few months, it reminds me a lot of those days, because anybody who questions anything that's being said is being told, are they an anti this, or they're a conspiracy theorist that, and actually critical thinking and freedom of thought and expression is required to actually do science properly. And as you know, there's a whole bunch of stuff we're being told now where the science is apparently completely disagreeing with each other. So it's an interesting thing to be doing CBT at a time like this, where you're told, do what you're told and don't question. I want to just say something about the most recent developments in CBT. There is a whole master's program at Oxford University in the UK, which is based on what's called mindfulness-based stress reduction. So it's mindfulness-based cognitive therapy. And more now, the traditional teachings of CBT that's based on the idea of programming, reprogramming yourself, actually incorporates meditation techniques within it. And the most recent, in terms of having a label, if you come across things and you say, what's the difference between CBT and DBT? Well, DBT, similarly to the one I was just mentioning, uses Buddhist mindfulness practices in combination with cognitive behavioral therapy. And what it does, the difference between it and the original forms of CBT, is to balance change, because CBT is all about changing yourself for the better, changing your thoughts, your feelings in a more constructive or positive way. But dialectical behavioral therapy also encourages acceptance of yourself as you are, or as you have been till now, so that you keep a balance between acceptance and change. And Marsha Lynham, who developed this system, was working with people with who'd got the label borderline personality disorder, and she found that they felt very threatened by the idea of changing too quickly. And so she started to bring in this idea of self-acceptance and, again, the mindfulness meditation practices. So if we go back to the saying that's ascribed to Gautama, the original Buddha figure, what we are, what we think, all that we are arises with our thoughts, and with our thoughts we make the world. Now, if you think about that saying, it's not that different, is it, from what we talk about nowadays when we say thought is creative, we can create things through our thoughts, and the secret and all that stuff, you know, the law of attraction and so on. But just to go back a minute to the history of this, the original roots of CBT in terms of psychology and psychologists are looking at behavioral, if you like, conditioning. So the first guy there you can see in the picture, that's Pavlov. You've probably heard about him and the dog salivating. You know, they would feed the dogs in the lab and they would ring a bell, and after a bit they wouldn't bring the food in, they'd just ring the bell and the dogs would start salivating. Okay, so this is what we call a conditioned reflex. So of course that's true of animals, it's also true of people, but what it doesn't take into account is free will and the difference between human beings and certain other kinds of animals. It got even more extreme with Skinner, who's the next guy along. He called it not conditioned reflexes, but operant conditioning. And Skinner was what was called a radical atheist. He believed that when people prayed, when they did rituals, basically what they were doing was actually believing that what they did made a difference, and it didn't, but they believed it, so they believed that that was the case. And he wrote a book, amazing title, called The Religious Behavior of Pigeons. And what he demonstrated in his research, what he demonstrated in his research was that if they fed pigeons after they went scratching around in a certain way, then the pigeons would think that their scratching around brought the food, so then they would go and they would scratch around, as pigeons do, and then they'd get fed. And so the pigeons believed that they were actually creating the food coming to them by their scratching. And he believed when people go to church and the mosque, when they go to pray, when they do practices, what they're doing is essentially the same as pigeons. They need to believe in something that's out there that's going to be looking after them. And so that's what they do. So he was not very, didn't have much time for what we would now think of as new age stuff and thought is creative. It's very much just manipulate people in certain ways and they'll behave accordingly. Things started to change for a bit more progressively in the second half of the 20th century, when we had people like Wolper, systematic desensitization, unlearning fear, when you can see AT, assertiveness training. So these people started saying, look, you know, we can condition other people in certain ways, and politicians can use that and advertisers can use it, but just suppose people apply it to themselves. So we have people actually unlearning their fears, their phobias. So That sort of thing, desensitization, is a part of what we now call CBT, what's called limited exposure. So you expose yourself to something that might cause you anxiety, and you go shooting up to 100% on the dial of fear and stress and anxiety, but the thing is you can't sustain that. And so if you actually find it fading off and you keep doing it more and more and more, eventually you're not bothered by that thing. So that's what the desensitization approach is based on. And anybody, I don't know, does EFT, emotional freedom techniques, the tapping on the meridians and so on. You've probably heard then of the SUDS meter. That's where it's called the subjective unit of disturbance scale, or it can sometimes be subjective units of discomfort or dis-ease. So measuring how uncomfortable somebody feels. This was developed by one of the early people in this field of CBT. And so if we move on from the history of that, these are the two guys that you need to know about in terms of where CBT came from in its modern form. On the one hand, we've got Ellis, who's known sometimes as the grandfather of CBT, and he was a psychologist who was a radical humanist, so he was very much a humanitarian, and he was quite radical in that he was prepared to stand up to conventional belief and wisdom, and he worked with the sexologist Alfred Kinsey, and you're probably all too young to remember this, but the Kinsey report you may have heard of was the first report that actually studied Americans' sexual behavior, because it's a taboo subject, because people don't generally talk about it or aren't honest about it. He did psychological research to find out, what do people actually do behind closed doors? What are their opinions? What are their views about sex? So Ellis worked with him on that. And Ellis, he trained as a psychotherapist in psychoanalytic therapy, and he found it to be ineffective. He found it wasn't actually making his clients well. And he started saying, you know, I think we need to make more interventions. We need to get actively involved as therapists to help people to understand how they are messing themselves up by the ways that they think, what he called catastrophizing, and that people's thoughts and feelings actually led them to have pain, emotional pain, and affected their behavior. Now, here's an interesting thing about CBT. He called his rational therapy, and I think you mentioned rational emotive behavioral therapy. Those were the labels he gave what he did. Beck came a little bit later. He was a bit younger than Ellis, and Beck was a psychiatrist who, like Ellis, went on to train as a practitioner of psychoanalytic therapy. Again, just like Ellis, he found that the psychoanalytic theory didn't account for his findings, particularly working with clients with depression. He worked with a lot of clients with depression, and he found that it was much more useful to be, again, active and help people to understand their distortions, the way that they thought, the way that their negative thought affected their behavior and their condition. And he developed a number of instruments that are still used to help us to assess how depressed somebody is. So I mention this because these two guys essentially developed pretty much the same ideas, but they didn't do it together. They didn't even know about each other until quite late on. And if you see this picture I've got up here, the two of them, cognitive behavioral therapy is actually a combination of Ellis's work, his rational emotive behavioral therapy, and Beck's work on cognitive therapy. And this picture you're seeing was, people felt it would be a really interesting idea to get them together because so many of their ideas were similar, even down to the techniques they were using. So they had one of these, you know, in conversation with, where they had an audience and they had them discussing. And at the end of that, they both realized that actually much of what they both developed was the same and could be combined. And they planned to start getting together and working together, but unfortunately Ellis died shortly after that, so that never happened. But Beck, who you can see over there on the this side as well, Beck is now, he will actually be 100 next year, and so he's still going strong, believe it or not, still very much actively researching, although officially retired, and his daughter runs the Beck Institute, supports this, and they're still doing active research in the Beck Institute. So what was the main thing they had in common? Well, it was that the thoughts, remember going back to the Buddha slide I showed you, that the thoughts, how we think, affects how we feel, and that in turn affects what we do and how we think. So we've got this dynamic triad of thinking, feeling, and behavior going on all the time within human beings. And the big idea that they both had was, if you can actually get people to rationally analyze their thoughts, their feelings, and their behaviors, and start to understand the underlying principles where they've gone off track, where they're giving themselves a hard time, where they're giving themselves this cognitive dissonance I mentioned, then you can actually help them to get clear. And ultimately, the goal of CBT is to help people to become their own therapists, to actually understand themselves and be empowered to go forward, which is one of the reasons I said to you, it's a very humanitarian. It doesn't have to be like a lab rat. It can be used in combination with these other more humanitarian, humanistic ideas, and with other modalities like hypnotherapy, like NLP, as long as they're modalities that believe in empowering people and not just labeling them, diagnosing them, and giving them medication. So the CBT basics, everything goes on in our mind, our memories, our images, our thoughts and attention. Behavior is everything that we do, how we act and how we avoid taking action, and how we solve problems. And therapy, of course, is a systematic approach to addressing problem, illness, or regular condition. And the central concept of CBT is that we feel the way that we think. Now that sounds great as a generalization. Of course, when you learn CBT, what you learn is how to actually specifically help people to identify that. So I'm going to just show you a few slides to give you an overview of that, and then you're very welcome to ask me questions about how that works. So CBT is very concerned with motivation. What motivates us to learn? And the two main points to look at here are extrinsic, right? What's going on the outside. So for example, in the current situation, your motivation to learn, to change your behavior, etc. from the outside is what? What's the two ways that you get conditioned at the moment to wear masks, to socially distance, to stay indoors for a long time before things started opening up? What was being used to get you to behave and do what you ought to be doing according to what the rules are? So somebody share with me.
First of all, it's the law now. If I go without a mask, I'm gonna be fined or imprisoned.
Yeah, so that would be what we would refer to as the operant conditioning, right? Your conditioning is, if you break the law, if you break the rules, you're going to be in trouble. So if you put that crudely carrot and stick, it's a stick approach, right? In this case, you'll be in trouble. Okay. Now, if we look at the other side of what happens on the outside, social cognition. So how do we also get affected in the current situation? Because it's a good one to take to understand this. So if you don't wear a mask, what will happen?
People are scared of you. Like if you pass by them, they, even with a mask, you know, it's people look at you in a way that you know, like you already are sick and you're like the virus, or you know, spread
Absolutely. It. So this is what we would call, sorry, I accidentally clicked that. Yes, absolutely. That's what we would call social cognition. So we want approval. And again, back to that pyramid of needs that I was talking about, we have social esteem needs. We want to be liked. We want to be loved. We want to be accepted. So when people say, you're putting people at risk, you're threatening the family, you're threatening other members of society, that would be the social conditioning, the social cognition, okay? So the prize for that, if you like, the carrot would be people will approve of you, they like you, they think you're doing a good job as a citizen. In the UK, people were coming out in the evenings and cheering and clapping for the health workers. So they were giving positive feedback to people who were doing their bit, right? So that's on the outside, extrinsic. Intrinsic is on the inside. And in CBT, and frankly, just about every other kind of good therapy, we say, this is really what you need to change. This up to a point, and it will work up to a point, but this is where change is required, because this is where we've got our thought, the cognition, affect, our feeling, and conation. Not everybody knows what that means. Basically, conation is the way that we act on our thoughts and feelings. And of course, we've got biology. We have our innate biology that we're born with and that we have. And there is also a spiritual element to it for some people, for many people, even if they're not religious, but they have a sense that there's something more. So when people want to change in therapy, this is what you need to really help them to do, is to find their internal motivation. And we have a joke in therapy. Some of you may have heard it, some not. And it's based on those light bulb jokes. You know, the old light bulb jokes? So how many people does it take to change a light bulb? So in this case, how many therapists does it take to change a light bulb? And the therapist joke is only one, but the light bulb has to really want to change. So that's what we mean by intrinsic conditioning, right? People need to want to change. This will only work up to a point. If people don't believe in it, and I see this now, I see it myself, if nobody's watching, if I don't think I'm going to be in trouble, fine, sent to prison, as you were mentioning, Ebtihal, I don't wear one because I've seen nothing in the science that tells me it's a good idea, and many things that have told me it's a bad idea to wear a mask of the sort of mask that we're wearing. So extrinsic, I'll do what I have to, but privately, I'll do what I think is right. So this is why as therapists, we work at this level. So in CBT, what we say is that we represent our experiences into what we call self-schema, the idea we have of ourself, and then we generalize from that. And so CBT seeks to go to the particular, the inductive. Okay, what specifically is that based on? What is the particular thought, the particular situation that led you to make those generalizations? And we hold these self-schema, these ideas about ourselves that are particularly important to us. And we have an example here. I'm a friendly person, a people person. So that's my frame, that's my schema about how I see myself. This person says, I don't trust others, I'm shy. So their idea of themselves is, I'm a shy person. And the problem is with this, in CBT terms, we have this package of self-knowledge. It limits us to how we see ourselves. If we see ourselves as a friendly people person, that's not a problem, right? But if we see ourselves as shy and awkward and not trusting others, that can really limit ourselves. So this is where CBT has in common with those of you at NLPers, the idea that we want to enrich people and their map. We want to expand their comfort zone so that they actually don't have that view that they're just this limited concept of who they are. And Beck's research, and he worked a lot with depression, which, as you probably know, is considered to be almost an epidemic now. In the UK, back in the early 2000s, they started referring, the health and safety executive of the country started referring to the fact that we have a stress epidemic, of which depression and anxiety play a huge part. And what Beck found was that there was a significant correlation to the point now, back in the 70s, they now feel it's not just a correlation, you know, there's not just a connection, but it's actually a causal effect. And that is that having a negative view of the situation, a negative view of oneself, and a negative view of the future is what actually enables us to tell how deeply depressed somebody is. So the job in CBT is to challenge the negative view of the situation, to challenge the negative view of the self, and to challenge the negative view of the future, and find out how much is that based on actual logic and reason and so on. And by the way, it's one of those things that's really important, and this is why I've mentioned it a couple of times this evening, for someone who is actually working in the scientific model and who's working in the rational and logical frame, which CBT is definitely part of. It's scientific, it's rational, it's researched very well. It's very, very difficult to do this congruently and honestly if you're not prepared to challenge general statements like what the media say, what the press says. So there is already, I predicted this a few months ago when this whole thing started, we're going to see more and more people justifying OCD because they're being told the germs are everywhere, there's contagion everywhere. So people who are germaphobes, people who are terrified of catching something, not long ago, we could actually get them to challenge that, see it was irrational. Now they're saying, actually, it's justified. And we had a guy who was on our recent CBT course we did, who's a clinical psychologist in Kuwait, who's on the emergency response team. And he had to miss a chunk of the course because he kept being called out. And in the last case he was called out on, it was suicide. So just think about this from a rational point of view. Someone is so afraid of dying from a disease which actually has a lower contagion rate than the regular flu, from what we can see now, killed themselves rather than live with the fear and anxiety that they're going to catch this disease and get this germ. So you see what I mean about the need to challenge irrational thinking. It's really important in CBT. So the goals of CBT is to identify the thoughts and beliefs by self-monitoring and education, so that people become more self-aware and understand the relationship between their thoughts, their feelings, and their behaviors. And we have an information processing model. So we look at, it's not what we experience, but how we interpret it. That's what makes the difference. And that is where CBT has in common with satir, with NLP, with so many other systems, because the thoughts mediate between the stimuli, such as external events and emotions. That stimulus elicits a response, and then there'll be some kind of judgment, some kind of evaluation that will go on. So it's not the stimulus itself that elicits the emotional response, but our evaluation about it and what we think about it. So I'll give you an example again, as we're talking about the current situation. Someone sees someone who's not wearing a mask, okay? So their immediate thought is, that's dangerous if they buy into the whole agenda that's being taught to us, being told to us by the authorities. Okay, so that's dangerous. So then that triggers a flight or fight response. They become very afraid, okay? That affects their behavior. They'll probably want to step away, get away from that person. But what does it also do to you when you go into a flight or fight stress response mode, when you become afraid or anxious? Anyone know what that does to you? What that does to your body?
It stops your mind. You know, you can't. It's an instinct. It's not something that you rationalize. You know, so
absolutely, you become, essentially, it's your amygdala, your lizard brain, the reptilian part of the brain for survival takes over. So we know, again, and this is very well researched, this isn't just someone's opinion, unlike some other forms of therapy. We can actually demonstrate that when someone is stressed or frightened, they actually produce the stress chemicals of adrenaline, noradrenaline, cortisol. When that happens, it switches off the thinking centers and the creative centers in the brain. So we get driven by survival, and then we're not able to think rationally, which is why you see people behave like terrible ways in mobs, in crowds, you know, and so on, because they've switched off their reason, they've switched off their logic, they've just gone into survival mode. The other thing that you didn't mention that I would like to share here is that it switches off your immune system response. Your digestive system, your immune system, your sexual and reproductive system are all bypassed or switched right down, because in that moment of survival, you don't need to have a sex drive. You don't need to digest what you're eating. That's why animals will throw up or pee or poop if they're scared, so they can run away or fight back if they need to. And your immune system is there to replace your cells, to fight off infections and viruses and all the rest of it. But in that moment, if your life's at threat, you don't need it, right? So this is the problem. When people start living in anxiety and stress, they actually get sick because they're not fighting off. So this is why, again, there's this balance to be had between being sensible, taking precautions, and being in a state of anxiety and fear, because that will make you more vulnerable to the very thing that you're afraid of in the first place. So this is why, again, CBT is really valuable at this present time, when becoming anxious, super anxious, going around all the time being in fear is actually switching off people's immune systems, their digestive systems. I know people having IBS problems, Crohn's disease getting worse, all sorts of immune disorders are affected by the stress response. So this is why, again, CBT is very valuable in helping people to understand how much is a reasonable, rational response and how much is just going into that panic, animal survival, stress response mode. Clients are encouraged to look at their negative thoughts and record their emotional states and triggers, and it's a very interactive therapy. Clients have to go out and actually do some observations on themselves, and we have a bunch of things like forms, or some people prefer to use journals, where we get people to start noticing what are the triggers, what are the things that actually make them unhappy, what are the things that cause them to feel fear or to feel stressed. And the thought process affects the feeling process. So if someone keeps thinking things like, I'll never have a good job, then guess what? They become hopeless and they stop even applying. Nobody likes me, so they never go out because I'm just going to get rejected, and they feel lonely. But if they think, I have solved problems before, then they can start to feel hopeful and positive and start to actually switch on those learning centers in the brain that I was talking about before. So the way that CBT works, in simply put, is stage one is to normalize, to get the person back into a normal state of thinking rationally and reasonably, and using a series of behavioral techniques. And this is where you can see if you're a hypnotherapist or you like people to encourage people to do sports, to do things like daily gratitudes, to focus and journal on positive things. These are all things that will help to switch on the relaxation response, which allows us to produce endorphins, the feel-good chemicals, the things that actually put us into a state where our learning centers can switch on, where our rational cognition, our thinking can be clear, etc. And experiments, including what we call controlled exposure. So we don't throw someone into the deep end, but we do encourage them to put in their toe into the shallow end and take baby steps until they build up their confidence. Okay, that's what's meant by controlled exposure. Bit at a time, not sudden flooding with big extreme fear, but just let's bit at a time start building up your resistance. Just as you build up physical resistance, you can build up emotional and psychological resistance and resilience. The second part of the process, having done that, having normalized the client's range of, whether it's depression, anxiety, or whatever, is to get them to start identifying and challenging their routine or automatic thoughts, to start to analyze the errors in their logic, which especially depressed people or people who are very anxious make. Use this Socratic questioning method and guided discovery, as we call it, to challenge and rewrite these thoughts in a more balanced, realistic way. So we don't say, oh, an affirmation, everything's perfect all the time, but we say, actually, I'm strong, I can solve problems, and each time I solve a problem, I feel better and stronger and able to challenge the next one. So it's incremental, okay? It's not absolute. It's day by day, improving, getting better, etc. You need at least 5 sessions to learn to identify and challenge these automatic negative thoughts and things that trigger these. And then the second part of this final stage, the client starts noticing just all through the day, what's going through my mind just before I started to feel this way. They start to draw up a list of what we would call thinking errors. The client takes on an observer role to reality test. Are these really true, or is it a hypothesis? Will someone hate me if I speak up in a meeting? Will someone think I'm not nice if I express my opinion? And so alternative ways of thinking start being introduced and substituted for those automatic negative thoughts. And of course, this is where, again, things like hypnotherapy and relaxation can help, where suggestion work can help, because it can enable the person to start accepting in the subconscious mind. The CBT deals with the conscious mind, but as I said, if you're using other methods as well, other modalities like hypnotherapy, you can help them to make changes much faster. And if I tell you the typical number of CBT sessions using CBT alone is around 15 to 20 one-hour sessions. When combined with hypnotherapy, we can get that down to about 6 sessions, sometimes even a bit less. Typically, I do longer sessions. I do 2-hour sessions, and I do 3 to 5 sessions is my typical number of sessions with people when I combine different modalities. And then the final, if you're just using CBT, the final sessions are to work with deeper core beliefs, the ones that are held in the subconscious. As I said, this is where hypnotherapy can be very helpful, and also to start looking at the negative themes that we have, like I'm not good enough, I'm worthless, I'm never going to change. And the client learns to capture these using either voice-activated dictaphone or mobile, or writing them down. Now, I'll tell you what, I like encouraging people to write them down, either in a form that I give them. There's various sorts of forms that we use. I like journaling and encouraging clients to journal. And the reason is because when you write things down, it uses a different part of your brain than when you're in a state of stress or anxiety. It actually forces your left brain to kick in, because that's responsible for organizing thoughts, words, putting them down in a sequence. So actually, by getting people to reflect on what's happened and what they're thinking and feeling, you're automatically taking them out of the fear and the stress response and anxiety and depression, and putting them into a more resourceful state where they've got to think about what they're doing. They're going to be more rational and more logical. So I want to just finish with a couple of other things. CBT and research. When people say, what do you mean, research? I mean research actually done, comparing control groups, actually having double-blind trials. There have been over 400 clinical trials for CBT, for CT particularly, which, as I said, is CT, CBT, are pretty much talking about the same things. And even, and this might surprise some of you, even in more extreme things like borderline personality disorder, which I talked about before, but also even in schizophrenia, which Beck has worked with quite a lot, using CBT, sometimes in combination with medication, has been found to be actually what Beck says now is actually a cure. People are getting better from conditions that are supposed to be lifelong, that you can never recover from. So I've given you a reference there if you want to look up any of this. And a couple of studies specifically to give you. In Toronto, they studied cognitive therapy against pharmacotherapy, in other words, medication, and they did pre and post-treatment brain scans. Both types of treatment did change the brain, but here's the big difference. With the cognitive therapy, the changes were top-down. There was a change in the understanding which started to affect the rest of the brain. The medication just basically kicked in, suppressed the primitive stress response, and therefore went up from there, having suppressed that. But the problem then is, of course, that doesn't last. As soon as you take the medication away, the person's still got the issue. When you start with the CBT, you actually change their way of thinking and their way of interpreting their experiences. So antidepressants dampen activity in the limbic system, which is the emotional center of the brain, whereas CBT calms the activity in the brain's seat of reason. So that's why, as I said, it's a lasting thing. Somebody dinging or? Okay, so we've got another 15 minutes, but I'll be finished in 5. So more importantly, perhaps, pharmacotherapy doesn't change the brain permanently, but cognitive therapy does. Therefore, there's much less likelihood of a relapse when people have done CBT. As I said, Beck, who's very scientific and very careful in what he says, cognitive therapy does seem to be a cure sometimes. So what you're doing is evidence-based work, helping the client to become their own therapist, to start to be aware of their own thoughts, feelings, and behavior. And of course, it can be very creative and flexible, because you can develop your own techniques, incorporate these into CBT. I'm trained in person-centered therapy, in breath work, in a number of different, EFT. I'm a trainer and a clinician in a number of different techniques. Hypnotherapy I've been doing for many years, and training in for many years. All sorts of things, and transaction analysis. I can incorporate all of that. I'm an NLP trainer and master practitioner and coach trainer. I can incorporate all of these things, and I don't have to stop and think, oh, well, what shall I, this is NLP. No, CBT is inclusive. As long as you're doing the basic things I've talked about, and there are obviously specific ways to do that, which we train people in, then you can incorporate those other modalities as well. This is one of the great things about CBT. It's not, you have to do this and you can't do this and you can't do that. It's very inclusive. So for those of you who are who have trained in hypnotherapy, as I said, I would just refer to this. CBT is structured and short, and so is hypnotherapy. They have that in common. One uses specific instrument and diagnostic assessments, whereas in hypnotherapy, that's not necessarily. If they're trained thoroughly, in my view, then they do learn how to do an initial questionnaire, and they do a fair bit of pre-session gathering of information, but not necessarily using the instruments or diagnostic tools. CBT identifies the core negative beliefs using the conscious mind, using inductive reasoning. Hypnotherapy does it, but does it by bypassing the cognitive rational. So the way that you do this, if you're combining the two, is do your CBT session first, and then you move into the hypnotherapy and do the suggestions and the analytic work, having already worked with the conscious mind. I find that works very well, because the conscious mind then doesn't interfere and interrupt and want to know what's going on. It's already been happy, convinced, it's got something to hold on to. It can let the subconscious get on with making the changes. Both use reframing, one in a conscious way, the other using parts therapy and using the hypnotherapeutic state. And also, CBT focuses on specific negative thoughts, seeks to challenge them and replace them with positives. Hypnotherapy does exactly the same thing. Both set a series of structured goals for change. Hypnotherapy isn't always so structured. Again, in my view, a good hypnotherapist does use structure. Hypnotherapy doesn't necessarily use a lot of homework. Some hypnotherapists give audios to listen to or various exercises to do. CBT is very strong on that. It says clients need to do their own self-help day by day as they go through. So if you were combining the two, you'd give them their CBT tasks, but you'd also give them some audio stuff that they needed to do every day. So positive psychology techniques can be nicely combined with these tasks. I don't know if you all know about the 5 daily practices from the Happiness Advantage, but that's a program that most of us put our clients on straight away. The 21 days of doing the 5 Happiness Advantage techniques. We talked about SUDS before, sorry, the subjective unit. Both of them use the subjective unit of discomfort. The big difference is that CBT doesn't revisit the past or conduct regression. The focus is entirely on the here and now and the future. So hypnotherapy, as you know, is present focused and future focused, as is NLP, but hypnotherapy does also use regression to find out if there's stuff that's repressed, that's stuck, that isn't moving. So again, this is why I think that CBT benefits from hypnotherapy, because some clients just still get stuck. They've got the conscious changes made, but they're getting a huge amount of subconscious resistance. When that happens, you can then use hypnotherapy to actually find out what that's about and to shift it. So both are active, both can be directive. CBT is directive and hypnosis can be directive. Both are time limited, both have structure, and both are importantly problem solving and solution focused approaches. And as I said, the research that's been done so far is showing very clearly that when you add hypnotherapy to CBT, you actually get better results. And there are a whole bunch of different studies that we'd like to see more, but there's quite a bit of evidence to show. And some people now are teaching what we call cognitive behavioural hypnotherapy. So it's a combination of the two. And that's something that we're bringing more and more into the training courses that we do. So CBT is flexible. It changes the maladaptive and rigid cognitions. It's based on the individual client needs. And there's just a list. I won't read through those of all the typical things that it can do that any good therapy is able to get good results in. And if you look at the 2 bottom ones, I just want to draw your attention to those. We actually teach a separate course. We have a 4-day CBT diploma for people who've got suitable backgrounds, but this is a 2-day only, but this focuses on OCD and eating disorders. And people sometimes say, why do you combine the two? Because both of them often involve similar mindsets. Both tend to have very rigid, dichotomous. That means they can only see black and white. It's yes or it's no. The 2, perfectionism. A lot of similarities in personality between people who suffer from eating disorders and from OCD. So we actually have a 2-day intensive that looks at the psychology of that, whereas the CBT diploma course focuses more on CBT itself and on depression, grieving, loss, the things that every therapist finds in just about every one of the clients that comes to them. So this is my last slide for you today. I've left us still 10 minutes if you're going to be brave enough to speak up, which a couple of you have, which many thanks. So our next short training that we're doing in, you too, especially Ebtihal's the star tonight for that. 2 intensive weekends from 10 in the morning till 6 in the evening with a break for lunch and just short comfort breaks. That intensive course is being run in combination with Illuminations. I believe that they're doing a 10% discount for the first 6 people to register. And this leads to, on passing the post-course exam, for which all the information is in a very substantial manual, as well as the course, you have, we're giving during this current phase 4 weeks to do the exam. We used to do 1 or 2 weeks, but now because of the whole situation, it's more tricky for people to manage their lives exactly. So for people who want to do that, who have a suitable background, and if they're not sure, they can always have a chat to me. Illuminations can set that up for you to have a chat to me about your situation. But it's not for people coming in complete newbies who've got no understanding at all, because it's assumed that you have some training in a relevant modality, in a caring profession, studying psychology, a coach, something where you actually have a background that means that you'll be able to take this information and put it into what you do. What we want you to do is, as soon as you pass the exam, start using CBT because it's a very straightforward, easy to learn model. That's why I love it, because it's so easy for people to learn. And those who are absolutely starting from first base, then we look at, okay, we've shifted now. We've just finished up the way we've worked for many years, which is to do a 1-year diploma in clinical hypnotherapy with psychotherapy and counseling skills, and then a second advanced year, which is expanding the psychotherapy. We've now integrated those, and as of next year, we'll be doing a 2-year, which leads to a UK accredited integrative psychotherapy and counseling qualification, and it includes certification in hypnotherapy, in CBT. We cover breath work, we do some energy psychology, etc. So that's more for the future, and you can keep in touch if you want to know how that's going to develop, but we're in the process of putting that through the accreditation process. But all that we do will have credits with it. It will have a number. I showed you earlier the sorts of people that approve it. So as soon as you've got your exam passed, you will get a diploma. And if I tell you that the people who did the exam pass mark, by the way, is 75%, because it's a scene exam. You know, you don't come into a classroom, we don't test your short-term memory under stress. You're encouraged to use the materials, but there's also a case study. And of course, a case study is something you really have to think about and show that you can apply the skills. But if I tell you, I was a bit worried about how people would do doing the course online when we're used to training face-to-face. If I tell you that a few people got in the 80 percentile range, and the majority of people got between 90 and 100%. We actually had somebody who got 100% in the exam, which is quite unusual, but the majority of people got in the 90s, the 80s or the 90s. So, and David actually said to me, these are some of the best batches of papers I've seen. So I'm just delighted to tell you that people are doing really well by doing this online. I'm not just giving my opinion now, I'm basing it on the groups that we put through since March of this year, where the first group did the first module face-to-face, then we had to shut down and they had to finish online. And then since then, another 1, 2, 3 groups have done online courses, and everybody's passed. And those who did the OCD and eating disorders, those who've taken the exam so far have passed very well. And we've got a batch just going through now who took that one. And we're not going to run that one again until November. That's right, it's on the slide. So any questions, any observations? Please feel free to ask me now. If you need to go, that's fine, but I'm just going to answer questions for a while. If anybody's got anything to ask me, please do.
Can I is anyone? So I'll start.
Go for it.
I watched a couple of videos from Milton Erickson, and as you said, he doesn't need to go through the process of inducing, you know, hypnosis. He just does it by language, which is very interesting. And I was, you know, always, it is fascinating to do it like that, while the person is he's just talking. So, but the thing, I know he's very like into his work, so he has his own science. But the use of language, I think, is part of your CBT, isn't it?
CBT in itself doesn't put too much focus on hypnotic language. It's focused on positive use of language, mind talk, self-talk, absolutely, but it doesn't use the subtleties of what we would call hypnotic language, which is why, as I said, to me, a CBT hypnotherapist has much more skill at bringing about those changes. And similarly, a very good CBT therapist just naturally develops and uses those things, which Milton Erickson, Virginia Satir, Fritz Perls, that's why Richard and John studied them, because they all use that language without knowing what they were doing consciously. They just naturally did it. But we can learn how to do what they did, yeah.
My question was not the inducing by using the language, which is, there's like, as you said, there's guided, I can read them and try them. It's the use of language itself, not particularly to hypnotize someone or induce it, just by using words, because you mentioned that by challenging the other person's mind by use of language. So this language needs like a guideline or like a How?
Yeah, I think maybe we're not, it's not that I think I'm answering your question in a way just to explain. When I say hypnotic language, I don't mean inducing hypnosis using either a script or not using a script. I'm talking about maintaining a state of hypnotic, deep relaxation and effortless concentration, what we call the relaxation response, in our everyday way of talking to people as therapists, not formally to induce hypnosis. There's a great piece of work showing Milton Erickson, where a woman says, I don't want to go into hypnosis. You know, I'm do therapy with you, but I don't want to go into hypnosis. He says, no, fine. We're not going to do hypnosis. And a little while into the session, he says something and she responds and people laugh because they're sitting in an audience. And she actually says, who's that laughing? He's induced a visual hallucination that she doesn't actually see the people. Now, that's why I said a good CBT therapist, in my view, who has either naturally or has learned the skills through doing NLP or hypnotherapy, uses that language in their way of talking to people to get them to actually look at their way that they're talking to themselves. They use humor. They use all sorts of devices. I mean, personally, I'm a great fan of Frank Farrelly, provocative therapy, where you're actually challenging a person, but you're doing it in a way that they can laugh at themselves. And as soon as you induce them laughing at themselves, then immediately they're in a positive state. They're producing endorphins all over the place. They're able to reframe. They're able to disassociate. So again, the skill of the therapist comes about through, as with all therapy, in my opinion, learning the techniques thoroughly and applying them to self and applying them to clients, because when you're doing that, then you're congruent, right? You're in alignment. So then when I say to a client, hang on a minute, you just said, oh, I'm no good at that. Okay, so how about we change that? Because I've taught them a bit about how it works. Okay, so I have been until now not much good at going out to parties. Okay, so you have had a problem. I've now put that in the past, okay? Now that is a classic NLP hypnotherapy type approach. However, I'm using that in the context of a CBT. Now, how would you like to talk to yourself about that? Okay, is that a rational thought? Where did it come from? Did you learn it from your mum or your dad? Or did everyone tell you that? Or was it teachers at school? Okay, so do you still go to school? Are you still a 5-year-old? No. Okay, so is that really the right thing for you as a 40-year-old woman to be still telling yourself? Well, no. Okay, fine. So what do you want to see? I'm just giving you a little example of how I'm using CBT, but I'm using hypnotic language, I'm using NLP and reframing, and that all goes together. Yeah, does that answer your question okay?
Yes.
And like anything, my students will tell you it's very boring for them, but I'm always telling them practice, practice, practice. If you do not practice, it stays purely up here. How it gets to be part of what you do is by doing it, right? So it's by learning. The techniques of CBT are very simple, really. They're not rocket science, but to do it well involves these other tools and skills and ways of applying. And it's, for me, I'm glad, I have to say, frankly, that I was engaged with other modalities first, because then CBT was beautifully fit with that. If I'd come purely into CBT, especially when I was younger and a student, I was really turned off by behavioral psychology. It was so deterministic, and I didn't really like it. But then also some of the Gestalt processes and some other kinds of therapy were way too crazy, you know, and we learned early on, if you encourage someone to keep catharting out their anger and bashing cushions and everything, it just makes them better at getting angry quickly. So, you know, I'm all about integration and integrative techniques, and CBT works beautifully in that way. But if someone's only using CBT and they have no understanding of the subconscious mind, of language, they're not going to get such good results as someone who has those other skills. I mean, the stories we know about Socrates, he used to go into trance. He used to walk along the road and he'd just stop there, and his friends would just let him stand there. He'd put himself into a state where he was going very deep inside to do that questioning process, and then he'd come out with a new idea or thought. So, you know, although CBT, we talk about Socratic questioning, I think he used trance state as well. I think he used that state of going into the subconscious state. So that's my opinion from what I've read of Socrates and know of him. Does that answer your question sufficiently? Great. Okay. This is Arshad. You have a question for me, Arshad?
Yeah, Dr. Laila, thank you very much for this wonderful session. First of all, you used several times this NLP. So when we apply the CBT and we are, the asking the question, so the hypnotic language means your mean is that the meta model of the NLP where we are asking, we are challenging the clients, because he is giving some generalized questions. So this is the first thing which I wanted to ask you. The second thing, as you mentioned, the diploma.
Can we deal with them one at a time? Can we deal with them one at a time? Because these multi-layered questions, it's hard to follow through and make sure you answer the question. So to answer your first question, yes, the CBT inductive approach is very similar to the meta model. The only thing is, whereas in the meta model, we'll be purely using the language structures, the linguistic model of the meta model, whereas in CBT, our focus is constantly on going back to the triad of the thought, feeling, action. And that actually makes it quite easy and quite nice for people to realize, yeah, this was the thought, that's the feeling that went with it, that's how I behaved, and it helps them find the triggers. What CBT doesn't have, that NLP does have in the meta model applications, is it doesn't have the sensory modalities understanding. So obviously someone who's an NLPer can shift, if they're proficient with CBT and NLP, they can easily shift into doing an eye accessing process or a closed eye process. They can change internal representation and so on, and then shift back into the CBT model. So that's all possible to do for someone who's a proficient NLPer. What was the second part of your question?
Yeah, my second question, as you mentioned the diploma in the CBT in the next month, I believe. So during this diploma, will you be using some part of hypnotherapy, or it will be exclusively diploma on the CBT?
The diploma is exclusively a diploma in CBT in terms of the qualification, but because of who I am, because of how I teach, because of David Cato, whose course we run under license, is a he was one of the first people to really bring hypno-CBT into the UK. He's retired now, but he's a master of CBT and of hypnosis, and he's also very well versed in NLP. And so we make reference to hypnotherapy techniques, to NLP language, that kind of goes alongside it. So for example, we'll look at a CBT intervention. What might that be? And some of the CBT interventions will be NLP techniques. Talk to the finger, talk to the hand, disassociate, use laughter, etc. So the way that I teach CBT, you've got all the principles that tick the boxes for a CBT diploma, but there is reference to hypnotherapy and CBT. I have to match it a little bit to the group, because if I've got someone who's got no understanding of hypnotherapy or NLP, I still want them to come out of that knowing that they can resourcefully use CBT. Say they've trained as a coach, but not an NLP coach, so they don't have any NLP skills, then I've got to make sure that in their coaching practice, they know how to use the questioning. But we've managed with, as I say, mixed groups. We tend to have quite a lot of people who've got some hypnotherapy and or some NLP experience, but occasionally we have people on the last but one course, we had someone who's a personal trainer who'd done no NLP. I think she might have done a bit of basic coaching, but she did personal training, and she really liked motivating people. She didn't find it a problem, and on the contrary, one of the things that's supplied with the course material, again reflecting that it's originally David's course, though we've made amendments with his permission, he supplies 6-session scripts, which are perfect examples of Ericksonian Milton model language used with the CBT techniques to actually enhance the state, so that once you've done your CBT session, you can put someone into a relaxed state and give them lots of suggestions. So there's actually quite a bit of material that goes along with the course. And I say to people, even if you've never done any hypnotherapy, you could actually read your client that script, put them into a state, just use some body awareness, put them into a relaxed state, do some muscle decontraction, then read them some of that script, and you'll find that it will be effective. And guess what it is? Obviously, it's not as effective or necessarily as flexible as someone who really knows what they're doing, has mastered something, but it gives them very good results. I know that from the feedback that they give us about the people that they work with as coaches. So it's a CBT diploma. It's called diploma. It used to be 2 courses, by the way. There was a CBT diploma, and then a diploma in the psychology of depression, grieving and loss. And we found it worked much better and there was less repetition if we merge them together. So we teach all of that, and the psychology of depression, grieving and loss is really important for any therapist, so it's useful for every therapist to know. But we put that with the CBT diploma, so we don't have to then go over the forms all over again, structure of a session all over again. They can do those 4 days and get the equivalent of doing about 6 days if they were doing them separately, if you see what I mean. So that's how we've condensed it down into the 4 days from what was originally about 6 days of training. And we prefer to do, we've tried spreading it out over longer periods. We found it didn't work so well. It works better when it's done as an intense weekend and then followed with another one, and then people do some reading in between. Then they have 4 weeks to actually go through all the materials, go through the exam, the case study, and as I said, the results have been very good from doing online, but there is an exam to do to get the qualification. If someone doesn't want to do the exam, they don't have to, but then they'd only get a certificate of attendance. They wouldn't get the qualification, the UK accredited qualification. Does that answer your second question sufficiently?
Yeah, thank you. Thank you very much.
Okay, good. Anyone else that I haven't heard from got any questions?
Follow me.
Go ahead.
Do you provide us with like materials or case studies or like manuals, books, something?
You get an extremely fat manual. When we are doing it in the classroom, it's usually 2 separate manuals because one is focusing on the CBT model and the other is focusing on the depression, grieving and loss. We have a couple of case studies in that one. We have more case studies in the OCD and eating disorders because not everyone has worked with people with these conditions. But we rather that people bring in, again, this is why it's not really for brand new people. We'd rather people actually talk about how they would apply it to themselves, to people they know, to clients that they have in whatever context they've got. So we do, it's pretty interactive. How it goes is it's heavy on theory in the beginning because obviously you need to know what you're supposed to be doing to be able to do it. And then as we go through, it gets more into discussion, case study. Some people choose to do something as a role play. Someone says, I had a client who did this, and then we use the CBT approach to see how they might have done it better. So, but the material that you're given, you could actually pass the exam by just reading the material if you really read it thoroughly and you had a good background. But obviously you would struggle more with the case study that you're asked to do if you hadn't had any support through the course, because the course materials don't tell you this is how you complete a case study, obviously on the course that's taught. And by the way, again, as I said, there's a bunch of slides, but you'll find, you can see it if you see the kind of feedback we get from students. I don't spend all my time reading out slides. I'll tell you the key points on the slides, but the point, I could send you slides, right? And you get them at the end of the course. But my concern is to give you illustrations. So if someone asks a question or asks an example, I'll quote to you from my own experience, case studies, my own experience of clients. If I ask you, tell me about that client that you had, and I tell you, okay, so what could you do with them using the CBT model? If you're not quite sure, I can chip in and give you some suggestions. So it's very much about drawing on the person that's teaching. I think this personally about any kind of teaching of therapy and practical skills is not doing things by the book, you know. Have I got the right answer? Is it the page answer on question 4? Have I got the principles so I can make this work? I can go out and apply it. So I'll give you a structure, and it is very structured CBT. This is why, again, people like it. They feel safe and comfortable with it. But within that structure, you have a great deal of flexibility and freedom as to what you do. So the answer to your question, the short answer is yes, there's a massive amount of written information. You get supplied with all David's forms, his self-help forms, what some people call homework. I don't like using the word homework because it triggers people's stuff about school and education and failure and all that. But you get those, and you also get guidance on the Wiley forms, which is something else I explain on the course, because there's a book called CBT for Dummies and a workbook, and CBT for depression and anxiety